Dr. Areeba Tareq, how are you?
Am I audible?
Can you hear me, Doctor? Walaikum salam. How are you, Doctor?
Assalamu alaikum. How are you doing?
Yeah, we are fine. Thank you for joining us today. It's a great pleasure for us. So we should start with Dr. Onur Yaman. Then you will be next, inshallah. Okay, Doctor? Can you hear me, Doctor? How are you, Dr. Yasser?
Walaikum salam, Dr.
Assalamu
Ahmed.
alaikum,
How
Dr.
are
Yasser.
you?
كيف الحال?
Fine.
How are you, Doctor?
I'm good. I'm good.
So today will be the moderator of today's session, and Dr. Asif, Professor Asif will be the chairperson. So you will start welcoming the audience and introducing speakers and moderate the sessions. I will be in the background. Okay, Professor.
Sure, sure.
So
So
you and Dr.
are the
Asif will take
Selamun
care of
Aleyküm.
the sessions. Wa alaikum
Can you
salam. How
hear
are you,
me?
Dr. Onur? Dr. Yaman, how are you?
Alhamdulillah. How are
Yes, I
you?
can hear you well. I'm fine. It's great pleasure for us, Professor, for your participating with us.
It's a pleasure for me. Thank you so much for this kind invitation.
The pleasure is ours, Professor. So
So
we should start
let
in
me.
5 minutes, inshallah.
Okay.
Okay.
So can you hear me? Is it fine?
Yes, I can hear you, but I can't see you, Professor. But I can hear you well.
So I have opened also the video. Let me go outside and come back.
Okay, no problem.
So can you see me now? I can't Sorry, Ahmed, I cannot hear you.
We see only black background. Check the lens of the camera if it's closed by something. Check.
So
We can hear you well, but we cannot see you.
I'm closing the video and opening it now.
Only black background. Don't know why. Yes, now I see you. Now it's good.
Selamun Aleyküm.
Alaikum salam, Professor. How are you? Now it's
Alhamdulillah.
perfect.
Okay.
If you would like to check a screen sharing, meanwhile,
Let me-
until we start, we still have 2 minutes.
Okay. So let me open my presentation.
Yes, good.
Okay, is it fine?
Perfect. Yes, it's perfect, Professor. That's good. Dr. Yasin.
Hello.
Yasir, how are you?
Hello, Dr. Onur. I'm fine. How are you?
I'm very good, Alhamdulillah.
Are we starting? Should I introduce, sir?
I'm ready.
Okay.
We can wait
I
for 1
think
minute for Professor Asif Bashir if he
Asif
will
Bashir.
join us in 1 minute. Otherwise, we can start. Okay, Professor?
Okay.
I will contact him now to see if I can join. Okay, Professor Dr. Yasir, if you'd like, you can welcome the audience and introduce our speakers, please. Dr. Yasir, I think we may have some internet connection issues. Dr. Yasir, can you hear me?
Yes, I can.
Okay, so please you can start welcoming the audience and introduce our speakers. And if Professor Asif Bashir joins us, he will join in the question and discussion
Sure.
section, inshallah.
Okay. Today we are hosting the WFNS Neurospine module number 4. This has been organized by the joint effort of the Yemeni Neurosurgical Society and the World Federation of Neurosurgeons. Today we have Dr. Asif Bashir, who is leading us, one of the most prominent surgeons in Pakistan, a very famous spine surgeon. Our speakers for today are well-known Dr. Onur Yaman, I know Dr. Onur Yaman since a long time. He has got an expert skill within the spinal deformity surgery. I had the honor of assisting him as well. He was a professor within the Turkey, and today he will be discussing about understanding the spinal deformities, their types, causes, and treatment options. So I would like to invite Dr. Onur Yaman to continue with his presentation and enlighten us with his skills. Thank you. Thank you very much. Dr.
Yasir,
Onur?
yes, I'm
Sir.
ready. So
Sir,
first
sir,
of
you
all,
can-
I'd like to thank to all of you, Ahmet, Yasir, and Asif for inviting me. Selamun Aleyküm to Yemen, Pakistan, and the other countries. So the topic is a huge topic. I'd like to make a summary about it. So how do we treat the spinal deformities? So we can divide the spinal deformities commonly in three different groups. Let's say the early onset scoliosis, adolescent idiopathic scoliosis cases, and the adult degenerative scoliosis cases. Starting from the pediatric cases, the early onset scoliosis. So the idea here is we have to correct the spine, we have to prevent the progression of the curve, but at the same time, we have to let the spine to grow up. So we have to prevent the curve progression. We have to correct the deformity as possible as we can. But during that time, we have to let the spine to grow up, because if you're doing a early fusion surgery, we're decreasing the forced vital capacity. And if the number is increased, the fusion levels, it decreases the forced vital capacity much more. So we have some techniques here. We can use growth-friendly techniques. There are lots of in the historical time, and we're using some of them, like tethering, stapling, Sheila technique, and growing growth technique. So we're using the growing growth technique. For this technique, we need a traction film. We have to determine the stable vertebra here. And during the surgery, we have to prevent the ligaments, the facet joints, and we need just superior dissection here. So this is a technique that we have used as hybridly. We have used the lower segment, but we have used a magnetic controlled growing growth here. So how do we use it? So we are doing the first surgery, and after that, the patient is coming for the controls every 6 months. So we are just finding the place of the magnetic controlled growing growth inside the patient. Then after that, we are just increasing 5 or 6 millimeters every 6 months. So we are just increasing the length of the rod inside. So this was a case with a congenital case with unilateral bar. The thing that we have done, we have removed the control, the one side unilateral bar here, and we have applied a magnetic controlled rod inside. How did we have done it? So we are just removed the unilateral bar, and after that we are inserting the magnetic controlled rod on one side, and this is after the operation, the control X-rays. Another case with 5 years old, that patient has hemivertebra here, had a progressive curve. So the thing that we have done, we have removed the hemivertebra because it was a segmented one. It means it's a risk for the progression of the curve. So we have removed the hemivertebra. We have compressed that on the convex side. And on the other side, we have applied a mechanical controlled growing growth. So every 6 months, we are bringing that patient again, and we're increasing the length of the screw here. So this is before, and after 6 months, we have just increased the length of the rod. So we are bringing that patient at the age of 13 so that we can do the final surgery to correct the spine. So if you don't have that magnetic rods, you can use the mechanical rods here with using the dominoes and the other devices. This was a 4-year-old girl, has Yemeni idiopathic scoliosis. So the thing that we have done for this case, we have applied the mechanical rods with dominoes here. So the patient will come every 6 months. So we'll try to control the curve, but at the same time, we have to let the spine to grow up and also to increase the force vital capacity here. So these are the postoperative view of that patient and intraoperative photograph of the patient. So this is another case. This case was a congenital, a syndromic case. You see there's a severe kyphosis and also scoliosis here. So we have corrected that patient. If you're looking just to the X-rays, you may say that it's not well corrected. But if you're looking to the clinical pictures, you see the patient has a good balanced shoulders now. We have corrected the spine. So we have a good cosmetic result here. So before and after the surgery. And this is a 10 years old juvenile idiopathic scoliosis case again. You see the bending films. So this was before the surgery and this was after the surgery, the clinical picture, the scoliosis has been corrected. So we can pass to the other topic for adolescent idiopathic scoliosis cases. Just a few slides in which cases that we have to use corset, in which cases we need surgery. So we have to know some terms here. The first one is Risser sign here. So if a patient has Risser 5, it means the growing has stopped. But if a patient has Risser 1 or 2, it means the patient has a potential to grow up, and it means there is a risk for the progression of the curve. And we have to see if the triradiate cartilage is opened or not. If it's opened, it has the potential for growing. If it's closed, it means we don't have a risk for the curve of the progression. So this table shows us if a patient has Risser 0 or 1, it means the patient has the potential for the risk for the progression of the curve. But if it's 3 or 4, we have less risk. And if the curve is greater, it has the potential to progress more. So this is a summary table. If a patient has a curve less than 25, the thing that we have to do is we have to wait and see to follow up that patient. If the curve is between 25 and 45 degrees, we can recommend corset. But if it's greater than 45 or 50 degrees, we can recommend surgery. We are talking about adolescent idiopathic scoliosis surgery. So adolescent idiopathic scoliosis surgery is just a cosmetic surgery. So indications according to SRS, if the curve is between 25 and 45, and if it's Risser 0 and 2, you can recommend corset. But if the curve is greater than 45 degrees, and if it's greater than Risser 3 or 4, if the curve is the upper thoracic one, don't use corset. So how do we, how do we make a surgical plan? In which curves we have to be include in the fusion and which levels? The main question in adolescent idiopathic scoliosis cases are that one. So if a patient has a curve greater than 25 degrees on lateral bending films, it means this is a structural curve, you have to fuse it. And if you're looking to the sagittal plane between T2 and 5, 10L2 and 10 to L2, if it's greater than 20 degrees, it means you have to fuse that level. We have lumbar modifiers, we have sagittal modifiers. So let me give you a few cases, examples here. Type 1 is you have just one main curve. Type 2, you have double thoracic. in double type 3, you have double in one thoracic, in one lumbar area. Type 4 is triple curve. Type 5 is lumbar. And type 6, you have again double curve, but the lumbar curve is greater than the thoracic curve. So where we have to start, the main question I think is that if the patient has a shoulder balance, if it's balanced shoulder, then you have to start from T4. If the left shoulder is down, you have to start from, this is the summary. Okay, there are lots of details here, but I'm making just a summary here. You have to start from T3, but if the left shoulder is elevated, you have to start from T2. So most of the cases in adolescent idiopathic scoliosis cases are right curves. It means when you're correcting this spine, the left shoulder will elevate it during the surgery. This is an animation of it. So we're correcting it. You see the left shoulder is elevated. So you have to control the left shoulder, and when you're finishing your surgery, the both shoulders has to be in the horizontal plane. So it has to be balanced. So where to stop? You need the lateral bending films. So the lowest instrumented vertebra has to be parallel to the floor. In this case, the lowest instrumented vertebra has to be L3. So we're using some maneuvers here. The first one is derotation technique. We have done this surgery in Pakistan, in Karachi. So I'm on the left side, on the concave side of the patient. So I have just bended the rod according to patient's thoracic kyphosis and lumbar lordosis. I'm on the concave side. I'm using the strong rod holders now. I have loosed the screw heads. So while you're doing that maneuver, one is rotating the spine, and the other surgeon is pushing down and to the medial to bring the spine to the rod. And we're just decreasing the rib hump on the convex side. So the question during that surgery was, how do we determine how many degrees we have to rotate the rod? The answer is we are bending it. Look, I have bended the rod according to the line. So I have to bring, let me show it again. So you have to rotate the rod 19 degrees. Now I'm showing the line here. So I know when the line is coming up to the floor, it means I have rotated it enough. So I have to rotate it more because the line has to come to the floor. So when you're correcting the rod derotation technique, then you're inserting the convex side rod inside. Now we're putting it inside. We're using the rockers and the other instruments during that maneuvers. So when we have finished the derotation technique, this was before the rotation, this was after the rotation. So when you're finishing it, there is another technique that you can use for segmental derotation. So let me show this animation. So you have to rotate the spine also inside. So we are starting to insert the towers inside. So we are adding the towers, then we are adding the bridges. This part is the caudal part. This part is the cranial part. So we have to start from the caudal part. So you see the handle of the bridge here. So I'm losing the screw heads and I'm derotating the spine segment by segment. So when you're completing the segmental derotation, we are fixing the head of the screws. You see the direction of the handle is in the normal position now, but these segments are still rotated. So we are doing it step by step. And while we are doing that maneuver, we are applying distraction maneuvers on the concave side and compressing maneuvers on the convex side. You see the instrument is very strong here. So during all these maneuvers, we are using neuromonitoring to see if we have a problem. If you have a problem, if you decrease, if you lose any signals in the neuromonitoring, you have to correct the maneuver that you have done. You have to come back. You see the direction of the handle is on the right side now. This is also in the normal position now, but this one is still rotated. So we are completing all the segments step by step. We are starting from the caudal, we're coming to the proximal part. So the last maneuver now, we are losing the screw heads. So every step you have to use the neuromonitoring to see if there is a loose there or not. So I'm passing to the last topic, adult degenerative scoliosis cases. If you want to operate an adult degenerative scoliosis, you need a plan. But before that, we have to be sure what we're treating. So are we just dealing with the pain? Are we just trying to correct the deformity? We have to decide according to the patient. Look, this is a 65 years old male. Everything was normal. But 1 week ago, the patient has started to walk like this. So if you're looking just to the X-rays, you may see that there is a scoliosis at the lumbar area. There is a sagittal imbalance. If you're trying to treat this X-rays, you will fail because there is a little problem at the L5-S1 level. If you're solving that problem, you see the deformity and the lumbar area and also sagittal imbalance has been corrected after the surgery because that sagittal imbalance was according to the pain. Another example, if you're looking just to the X-rays, you will see there is an increased SVA, but the problem was just a disc. We have solved the disc problem, and after that, the patient has a good sagittal balance. So if you're treating the pain, and if you know the cause of the pain, like disc, lateral recessus, or whatever it is, if you solve that problem, you will correct the sagittal imbalance, also the lumbar scoliosis problem. But in the cases which is chronic, this is totally different. So we have to analyze the deformity before planning a surgery. We know the SVA, but SVA is not enough. We have to know the pelvic incidence. We have to know the type of the curve so that we have to know which level we have to fuse. So we know that parameters, this difference between pelvic incidence and lumbar lordosis, the pelvic tilt, and the other parameters. And we should know the lumbar lordosis according to the pelvic incidence, because the pelvic incidence is the fingerprints, and we have to decide the lumbar lordosis according to the pelvic incidence. So if you have a normal pelvic incidence, commonly we can see that 2/3 of that lumbar lordosis has to be at L4, 5 and L5-S1 level. So your rod has to be more curved on the distal level. So let's analyze this patient. The patient has a severe kyphosis and lumbar lordosis, had 3 previous surgeries. So we need a plan before the surgery. So we need the X-rays. You need a software to make the plan. I'm using SurgiMap. So I have to do some osteotomies here, but which type and at which level? So I'm trying now before the surgery. So you see, if I do a L4 PCO or type 3 osteotomy, it's not enough because I cannot bring that patient much enough I want. So I'm adding a Ponte osteotomy on it, type 2. It's not enough. I add a double Ponte. Again, I'm changing the type of the osteotomy now. I'm applying a corner osteotomy at level 4. It's not enough. So this is my plan before the surgery. If I apply a L4 corner osteotomy and if I add 2 Ponte osteotomies, it will be much enough for me. So the thing that I'm doing here, I'm just bending the rod. The rod you see in blue color is the rod inside. I will start from T10. I will come to iliac wing. I know the shape of the rod now. So I'm just having the 3D version of that rod. So I'm sending to the company and saying that bring that rod, bend it according to this 3D shape. So they're bending it. And after that, if I can apply this rod easily during that surgery, it means I have a good lumbar lordosis and I done what I've planned before the surgery. So during the surgery, I'm taking two different C-arm views because you cannot get all from L1 to S1. I'm combining it during the surgery, one from L1 to L4, let's say, and the other one L1 to S1. So I'm leaving the surgery, I'm going in front of the computer, just combining the films and see if I have it, the proper lumbar lordosis. You see, I have a 33 degrees lumbar lordosis during the surgery, according to the X-rays that I've got in the surgery. So this is after the surgery. This was my plan. And this is the post-operative view. On the left side, you see the plan. I was planning getting a 39 degrees lumbar lordosis according to pelvic incidence and according to the age. And after that, you see the lumbar lordosis on the right side in green color, it's 38 degrees. I commonly get the proper lumbar lordosis. And this is before and after the surgery, the walking of the patient. Another case has been operated several times, but you see there is a lumbar kyphosis on the left side, so we need to make a plan. We have bended the rods before the surgery. This is the intraoperative views. We're using a T shape to see if we have a coronal balance during the surgery or not. So the T-shape rod has to be inside the rod that you have put inside. If the rod is outside, it means you have a coronal imbalance. So you have to check it during the surgery. And another trick point here is while you'll finish the surgery, the L4 has to be parallel to the floor. So L4 is parallel now, before the surgery and after the surgery. So keynotes for adult degenerative scoliosis. The complication rates are very high. It's in the literature. It says that 40% we may have complications and we may need revision surgeries. Because of that, we have to talk very clear before the surgery. You will need a revision surgery. So if we can do it, we have to minimize the surgeries, the fusion levels. But all of them, we need a surgical planning before the surgery. So these are the things that I want to say. I try to make a summary about it, trying to collect everything in 25 minutes is difficult, but I tried my best.
Thank you very much, Dr. Onur, for such a wonderful talk. It was a very comprehensive presentation covering all the aspects along with the examples. So I would like the participants to share any questions they have within the chat. And if it's okay, Dr. Ahmed, I think should we do the other presentation first and then answer the questions in the end?
So
Yes,
Yasir,
that will be great.
so Yasir, Ahmed, is
Yes.
it possible so that if nobody has question, may I leave because I have to enter another meeting?
Okay, so just if anybody has questions, they can share right away. We have Dr. Onur right here with us, and he has to go. So if we have any questions right now, please do share so we can answer them, and so that Dr. Onur can go for another meeting. I think Dr.
So
Onur,
Ahmed, did you like the presentation?
Yes, thank you, Professor. It was a great presentation and very concise, and you get the most important points of the deformity surgery. So,
So
very nice
these are
presentation.
huge different topics, okay? You have to think totally different in pediatric cases. Let's make a little summary about it. So you have to correct the spine as soon as possible if you have a risk factor like hemivertebra or tetrad cord or diastometamyely, you have to solve the problem, okay? And if you see a segmented hemivertebra, you have to remove it, but try to fuse it just one level above, one level below. And you have to follow that patient. During that following, you have to use some friendly growing techniques that I have shown you. The growing rod technique is a good technique. But the magnetic ones are expensive. Then we have to do, if we cannot apply it, we have to apply the mechanical ones. So the disadvantage of mechanical ones, you need every 6 months a surgery because you have to open it, that the connectors, let's say the dominoes part, so that you can distract it. So every 6 months you need a general surgery, general anesthesia for it. But you have to do it. You have to need to prevent the progression of the curve. For the adolescent cases, so it's a cosmetic surgery, okay? For that adolescent idiopathic scoliosis cases, try to use corset between 25 and 45 degrees. And if it's coming over 45 degrees, there is no need for the using of corset. Then you may recommend scoliosis. I'm just saying that you may recommend, okay? Because it's not a necessary surgery. I'm talking about adolescent idiopathic scoliosis cases. And when you come to the adult degenerative scoliosis cases, the complication rate and the revision surgery rates are too high. So the patient has to know it before the surgery. Let's say you're starting from T10, you're coming to iliac wing. So if you're starting it, 2 of the 5 patients will come back. You will lose the upper screw, you will lose the iliac wings. You may have a proximal junctional kyphosis or distal junctional kyphosis problem. So the patient has to know it before the surgery, so that if you can do a minimal surgery, minimal invasive surgery, or less fusion surgery, but if you're applying instrument inside, you have to do it according to the rules. If you're doing just putting screws on the upper of the apex, you're starting a deformity then. I don't know who said that. Every spine surgeon is a deformity surgeon, okay? Someone is creating the deformity, the other one is trying to correct the deformity. Okay, thank you so much.
thank you.
Thank you, Professor
Uh,
Anur. Very nice presentation.
Ma salam.
Thank you.
See you, Doctor.
See you.
I think we have our, so thank you very much, Dr. Onur, for the presentation. Now we have
Yeah.
our second presenter of the day today with us. The second presenter today is Dr. Areeba Tareq. Dr. Areeba Tareq is currently working as a young consultant within Pakistan. She has done her fellowship in surgical neuro-oncology from Shaukat Khanum Memorial Hospital, and also she is a gold medalist within the FCPS neurosurgery in Pakistan. So she will be talking today about the spinal infections, diagnosis, their causes, and management options. Over to you, Dr. Areeba. Dr. Areeba, can you hear us?
Am
Dr.
I
Areeba, you
audible
can
now?
unmute.
Yes, you are
Yes, we
audible.
can hear you now.
Your presentation is visible to us.
Okay. So, Assalamu alaikum. I'm Areeba. Let's start with spinal infections. We will briefly touch the diagnosis, causes, and management options. So the learning objectives that we basically want you to learn about spinal infections, how to diagnose them, what are the common causes, and the medical and surgical management options that are available. So starting with the simple definitions, it's an infection condition that affect the vertebral body and intervertebral disc or adjacent paraspinal tissue. It can arise via hematogenous dissemination, direct inoculation from surgical procedures of trauma, or from adjacent infections. It has a very non-specific presentation usually, leading to delayed diagnosis, and that is why we need to have a very strong suspicion for it and increased risk of neurological deficit. Just a little bit of history, how it started. Well, we have first documentation of spinal tuberculosis, 1779, and again 100 years later from France about pyogenic osteomyelitis. Usually, the interchangeable terms about what is spondylodiscitis and what is spondylitis that we will learn later on. So, just for review, discitis is inflammation of disc, intervertebral disc, and it's common in children. These are all spinal infections. Spondylitis is vertebral end plate and vertebral body infection. It's very similar to osteomyelitis, but it's usually seen at earlier stage of infection in adults. Spondylodiscitis, as the name suggests, it's infection of the disc and adjacent vertebral body, and it's the most common form of spinal infection that we usually see in clinic. The septic facet joint, or usually involves the facet joint, usually is caused by the spread via blood to the facet joint, and very common nowadays. Epidural abscesses, as the name suggests, they're in epidural space. They're rarely seen isolatedly, but contagious spread of infection into the medullary canal can happen with them. How common are spinal infection? Well, they make about 2 to 7% of all musculoskeletal infection. And in developed countries, it's 1 in 1,000, 100,000, or 1 in 250,000. But mortality is around 2 to 4%. There's a bimodal distribution. It's usually peak in individuals younger than 20 years, and then again recurring in those whose age is between 50 and 70. It's more common in men, somehow 3 times more common. What are the common factors that lead to development of spinal infections? Well, the most common is previous spinal surgery. And what are the factors in spinal surgery that lead to spinal infection? Well, long duration, high blood loss, implantation of instrumentation, and multiple revision surgeries at the same site. Usually it happens in 1 to 4% of cases despite all the preventive measures. It can also happen because of another infectious focus, diabetes mellitus, advanced age, IV drug abuse, HIV infection, which can lead to immunosuppression, oncological history, renal failure, rheumatological disorders, and liver cirrhosis. So we basically divided into pyogenic types and granulomatous types, and is caused by 3 primary pyogenic bacteria and rheumatus infection, and very less likely, less frequently, we have a parasite-induced infection as well. So in the past, tuberculosis was a very important cause, the leading cause of spinal infection. But now it has decreased recently in developed countries, but still a common problem in Pakistan and developing countries. Currently, Pakistan ranks 5th globally for tuberculosis, and it carries 75% of the total TB burden of the region. So how does the bacteria reach the spine? It actually reach via 3 routes, either via hematogenous spread from a remote site, direct external inoculation after trauma, like after spine surgery or any injury, or via dissemination from contagious tissue. Hematogenous spread is the most common route for vertebral osteomyelitis in children. And infection in the urinary tract, often after genitourinary procedure, is most common source of transient bacteremia and subsequent spinal infection in adults. What are the causes? Infection anywhere in the body, like air, GI tract, oral cavity, skin, soft tissue, respiratory tract, anywhere. And in almost 50% of the cases, you cannot find a cause. There is no source of infection. Secondary spinal infection, usually due to direct inoculation, can occur after spinal surgery or minimally invasive spinal procedure, such as chemonucleolysis or discography, or after penetrating trauma in the spinal area. So how does it happens? Well, basically, the adult intervertebral disc is avascular, as we all know. So the same vascular pedicle that bifurcates and supply the two adjacent intervertebral end plates. So it usually involves both of them together, because if one pedicle is involved, it's going to spread infection. Similarly, the slow blood flow in these vessels, there's a lack of valves and convolution of the arterial or venous supply. It makes vertebral column more susceptible to develop an infection in patients with bacteria. Now, in children, as opposed to adults, the infection can spread more easily since the blood vessels in the end plates extend to supply the intervertebral disc as well. That is why discitis is more common in children. The spread of spondylodiscitis to the posterior surface is rare because of the vascular supply of the vertebra, and it is usually seen in fungal and tuberculous spondylodiscitis. One of the features we are going to see again and again. Now, today, the most common isolated pathogens that we see in pyogenic cases of spinal infection is Staphylococcus aureus. Incidence rate about 30 to 80%. Other causes are E. coli, Mycobacterium tuberculosis, usually in HIV patient, and anaerobic infections. So, what region is usually involved? We know the organism that is commonly involved. We know the root that is commonly involved. The region is lumbar spine, 58%, in pyogenic spondylodiscitis as well as in tuberculous spinal infection. In TB, however, thoracolumbar and thoracic spine is involved second, 38 to 49%, and cervical is the least involved area. How do patients present to us? Well, it's a very varied type of distribution, but generally pain is localized initially at the site of infection. If the patient is post-operative, you will have symptoms like wound drainage, redness, swelling, or tenderness near the incision. Although fever is a common symptom, it's not always present. And approximately 50% of patients with pyogenic spine infections and even higher percentage of patients with fungal and mycobacterial, they are basically afebrile. Adult patients often progress with the following clinical stages. First, they have a severe back pain with fever and local tenderness in the spinal column. It progresses to a nerve root pain radiating from the infected area, leading to weakness of voluntary muscles and bowel bladder dysfunction, and ultimately to paralysis. However, in children, the most overt symptoms are prolonged crying, obvious pain when the area is palpated, and hip tenderness. So, a very vague and different kind of presentation. Now, what do you want to examine such a patient who present to you with similar complaints? On physical examination, inspection should assess for any scar, like we should indicate a previous surgery or trauma. Any deformity such as kyphosis or scoliosis should be noted. On palpation, paravertebral muscle spasm should be felt, while marked tenderness with percussion over spinous process of the infected spinal spine is more consistent finding. It usually present in 75 to 95% of cases. Approximately 30% of the patient will have neurological symptoms like paresthesia and muscle weakness as well. How will you make a diagnosis? Now, it's very challenging. To make an early diagnosis before serious morbidity occurs, it typically takes an average of 1 month, but can take as long as 6 months, impeding effective and timely treatment. And many patients do not seek medical attention until the symptoms become severe or debilitating because they're very vague symptoms. Starting from the basics, lab test. 4 things that you can check: WBC, which is normal in 55% of cases, ESR, CRP, and blood cultures. Blood cultures are usually taken during a fever spike. They can help identify the pathogen involved in a spinal infection. Now, about ESR and CRP, they both are very good indicators. They indicate inflammation, but CRP is considered to have higher sensitivity as compared with other blood tests. And it is also a useful marker for response to antimicrobial therapy once you start the treatment. Moving on to imaging, plain X-rays, I know they're very old, but again, they're very basic in assessment. They should be done. They have a very low specificity in the diagnosis of spondylodiscitis. What they can show is just irregularities of the vertebral end plates or low intervertebral disc height in advanced cases, but they can be useful as a basic first assessment radiologically. And flexion extension X-rays can be useful in follow-up period for detecting a possible instability. This is how a plain conventional X-ray will show you end plate changes, leading you to a suspicion of spinal infection. Next step, CT scan. Now, CT is for bone destruction, and it can be normal in the first 3 weeks, but it can later reveal fragmentation or erosive changes in the vertebral end plates, ill-defined reactive sclerosis or osteopenia, intradiscal hypodensities, or soft tissue swelling that obscure the fat planes surrounding the vertebral body. This is how the end plate changes can look in CT scan. End plate erosions. Now, MRI, the investigation of choice, the gold standard, with or without gadolinium contrast. It is usually sensitive in 96%, specificity of 93%, accurate in 94%. So the investigation of choice. What are we going to see in a typical MRI? We are going to see hypointense vertebral bodies and disc with loss of end-plate definition on T1. Hyperintense vertebral bodies and disc with loss of end-plate definition on T2 or stir images and contrast in him. Now, this is how it should look like. On T1, we see hypointensities. On T2, hyperintensities and plate destruction and erosions. Now, I don't think we have an option of questions, but this sign, this is a nuclear cleft sign. What is a nuclear cleft sign? It's usually present in normal individuals after in third decade of life. When you see this in T2 weighted images, there's a cleft. So the non-visualization of this intranuclear cleft in a disc and surrounding increased T2 intensity on an MRI is very highly suggestive of infection. It's a marker that we can use. After gadolinium contrast administration, enhancement of the subchondral bone or vertebral body may be observed, and the affected disc show diffuse enhancement. In some cases, we can see an abscess on T1 and hyperintense on T2 and contrast enhancement. Pyogenic spondylolisthesis generally less frequently affects the posterior elements of the spine. This is something that we learned before as well. Posterior elements are usually involved by the granulomatous spondylolisthesis. So, how do you differentiate between the two? This is something very important and very useful information for endemic countries of TB. So, thoracic spine is more commonly involved in tubercular spondylolisthesis. If you see a subligamentous spread to 3 or more vertebral bodies, then usually it's a tubercular spondylolisthesis because pyogenic spondylolisthesis usually involve less than 2 or equal to 2 vertebral bodies only. Posterior element involvement is present in tubercular spondylolisthesis. The paraspinal surrounding the spine sinuous, they are very common in tubercular spondylolisthesis. Paraspinal abscess is also very common in TB, but epidural abscess, again, it's also common in TB. Intraosseous abscess, that is the presence of pus inside the bone, it is also common in TB. The abscess wall in pyogenic infection is usually thick and it's irregular. And vertebral enhancement is homogeneous or diffuse. T1, T2 enhancement is also diffuse in pyogenic type and it's heterogeneous in TB. Destruction of vertebral body is very severe in TB. This destruction is severe in pyogenic spondylolisthesis. Now, very brief overview. In different types of spinal infection like spondylolisthesis, tubercular spondylolisthesis, epidural abscess, subdural abscess, septic fasciitis, what we are going to usually see in one word, T1 hypointensities, T2 hyperintensities, contrast enhancements. So what are the nuclear studies that we can use if we want to go further? So there are 3 things that we should have an idea of. We have FTG PET scans, 18F preferred nucleonuclide test for suspected spinal infection, very sensitive, and it's very useful in distinguishing between active infection and degenerative changes like modic changes. And it's also the modality of choice for patients with metallic hardware as it avoids metal artifacts that degrades MRI images. Other thing that we can do is bone scintigraphy. They can help in detecting bone remodeling, hyperemia, and osteomyelitis, but suffers from low specificity since tumors and fractures also cause increased uptake. Other are gallium-67 and indium-111, labeled WC scan. Tissue diagnosis, the gold standard of diagnosis, diagnostic in 80% of cases. Now, we can take an open biopsy or a CT-guided biopsy. CT helps us to determine the safest approach to the lesion and helps in accurate needle placement in the lesion. And now it has become the procedure of choice compared with open biopsy because there is less risk of infection, iatrogenic injury, and wound problems. It's also fast, economical, and applicable to OPD patients as well. So the algorithm of treating or diagnosing a spinal infection is if you have a clinical suspicion for spinal infection, based on medical history and physical examination, you go for lab tests, which are 4, WBC, ESR, CRP, blood cultures. You go for imaging evaluation, which is plain X-ray, MRI, CT, or retinal imaging only when MRI is contraindicated. If you have a positive or inconclusive MRI, you go for a CT-guided biopsy. You take sample from it and you consider testing for it. If the pathogen is identified, you start a targeted antibiotic. But if the biopsy is negative or you don't have a plausible pathogen, you consider second needle biopsy or an open biopsy. And once you identify the organism, you start treating it. So how do you treat it? Of course, there's a medical management and there's a surgical management. The goal of conservative treatment for patients with spinal infection is eradication of infection and pain relief. So we have two goals. We have to remove the infection, we have to give pain relief. While spinal stability is preserved and neurological dysfunction is prevented. In approximately 90% of the cases, conservative treatment is successful in achieving these goals, and it includes appropriate antibiotic therapy combined with spinal brace, immobilization, and physical therapy. Bed rest is usually recommended initially, especially during the initial period, because it relieves the pain and it prevents spinal deformity. And it should be approximately 1 to 2 weeks or until the patient has an improvement in pain. Now, once the period resolves, the patient can be ambulated with a spinal brace so that it helps in early recovery. Despite the high rate of success with conservative treatment in patients with imaging evidence of progressive destruction of the spinal column or with progressive neurological deficit, conservative treatment should be discontinued and surgical treatment should be performed. Similarly, when you cannot have a clinical improvement after initial period of conservative treatment of 6 weeks, you should think about surgical treatment. If the patient is critically ill or when cultures are negative, a dual-agent empirical therapy, including a third-generation cephalosporin or fluoroquinolones plus a clindamycin or vancomycin is recommended. Until isolation of the causative pathogen, empirical treatment should include clindamycin in normal individuals. Clindamycin or vancomycin or fluoxetine plus cefepime or ciprofloxacin or ceftriaxone. To cover a wide spectrum of potential cultures, your antibiotic therapy should be modified based on the cultures. So, if you have Staphylococcus, Streptococcus, or MRSA, you usually go for clindamycin, fluoxetine, vancomycin, teicoplanin. If you have gram-negative bacteria, you go for ciprofloxacin, ceftriaxone. In anaerobic bacteria, usually we give chloromaphenicol, amoxicillin plus carbonic acid, or meropenem. Now, what's the optimal duration of antimicrobial therapy? Now, this is a very highly debatable topic, but there's a wide variety of recommendations. Most authors usually recommend a period of 4 to 6 weeks, while some recommend a longer period of up to 3 months. In a recent RCT that I have mentioned in the sub-slides, they enrolled 359 patients with pyogenic spondylitis cystitis, and they concluded that a 6-week antibiotic treatment was similarly successful and safe to 12-week treatment. Antibiotic therapy can be discontinued when clinical improvement with resolution of symptoms is evident and the inflammatory markers are normalized. The marker that we usually use to follow is CRP. Patients with spinal tuberculosis should be administered longer. It's usually 9 to 12 months of antibiotic treatment. So when do we go for surgery? Well, very simple. Failure of conservative treatment after 6 to 8 weeks, sepsis, progressive neurological dysfunction, spinal instability, epidural. Although in most cases surgical treatment is not needed, almost 50% of patients with spinal infection will undergo some sort of surgery. Usually adequate surgical debridement and decompression is feasible only through an anterior approach, since in most cases the vertebral bodies and discs are affected, and in TB we know that postural elements are involved. In many cases, surgical debridement results in spinal instability. Therefore, an additional stabilization procedure, like with bone grafting or spinal instrumentation, is required. Moreover, in anterior fusion only is not adequate in most cases, and a combined anterior posterior approach with supplementary posterior stabilization can be required, especially if it's multi-segmental involved. Although we can use large strut autograft for fusion due to their high risk or rate of consolidation, but they are associated with donor site morbidity. Therefore, instrumentation such as with titanium cages as well as transpedicular screws and rods are commonly used. A prerequisite for spinal instrumentation at time of debridement include thorough debridement and concomitant antibiotic therapy. If the patient is postoperative spinal infection and you have an infected implants, you need irrigation and debridement with implant removal. If it's late postoperative infection, it's usually recommended to be treated with implant removal first, given that solid fusion has been achieved. Complete debridement is not feasible because areas such as spinal anchorage points or the region directly under the rods are relatively inaccessible without removing the instrumentation. So the algorithm will be if you have an indication of surgical treatment, that is septic, if the patient is in sepsis, if you have spinal instability, if there's an epidural abscess or a paravertebral abscess of more than 2.5 centimeter, or if the spinal cord and nerve root compression is present with progressive neurological deficit, you go for antibiotic empirical therapy and surgical management. Surgical management includes surgical management and decompression, stabilization position, either could be grafting or instrumentation. If the patient does not have these surgical indications, then you go for a bed rest for 1 to 2 weeks, ambulation with spinal brace later on, and targeted antibiotic treatment. The total duration of antibiotic usually is 4 to 6 weeks. You give IV antibiotic for the first 2 to 4 weeks, and later oral antibiotic for the next 2 to 4 weeks. If the treatment is successful in 6 weeks, good, you're good to go. But if the patient treatment is not successful in 6 weeks, then you go for surgery. Now the take-home message, if I'm going to summarize all the slides, the diagnostic approach of patient's spinal infection should include blood workup, blood or CT-guided needle cultures, and histology, and imaging evaluation with radiographs and MRI imaging. Most patients with spinal infection diagnosed in early stages can be successfully managed conservatively with antibiotics, bed rest, and spinal braces. The commonly used antibiotics empirically that we should remember are vancomycin and a third-generation cephalosporin, or a fluoroquinolone to cover MRSA and gram-negative organism. But other antibiotic regimen with similar coverage can be used as well. If you want to use implants, titanium implants are the optimal hardware for stabilization following debridement due to their favorable properties resulting in less biofilm formation. Thank you. I'm open for discussions.
Thank you, Dr. Areeba, for such a nice and descriptive presentation. The forum is open for any questions. If somebody has any questions, kindly share them in the chat box so we can discuss them with Dr. Areeba. Meanwhile, I have a question, Dr. Areeba. You just described that when there is an infection present and it's a post-operative infection, we usually remove the implant. And ideally, in most of the cases, we are already using the titanium implants. While their infection is spread from some hematogenous route and there's instability, then you are going to fix the patient with the same titanium implant. So how do you address this dilemma? That if I know in tuberculosis the implants work fine, but if it's not tuberculosis spondylodiscitis and it's a pyogenic spondylodiscitis and you are putting in titanium screws, how do you justify that those screws would be successful and would not result in a continued infection?
See, the titanium is the best material that we currently have that has a low chance of forming a biofilm on it. The thing is, why do we remove implant in the first surgery is because there are certain inaccessible sites beneath the implant or underneath the implant that may be harboring the bacterial infection, pyogenic infection. So if we are doing a post-op wound debridement, we need to remove the implant so that we can access those sites where bacteria could be hiding. But once, of course, the wound is clear and you're okay with, then you need to have a fusion because spine is unstable. So the best option again that we have is titanium implants.
So it means that in such cases, you would remove the implant, you would do debridement, and then you will again go to fix the patient later on.
Yes, if the patient has instability, yes.
In the intervening period, we will keep the patient on the bed rest.
On immobile and spinal brace later.
Okay. So, Dr. Ahmed, if you have some questions, maybe you can share.
I have a question. In some cases, we cannot identify the pathogenic cause of infection. So we can start with empirical treatment in some cases. What do you choose for this empirical treatment in such cases?
So as I shared, for empirical therapy, it's usually third generation cephalosporins along with coverage with imipenem or vancomycin. And you do it, like take it for 4 to 6 weeks, you see clinical improvement, it's present or not, or you can continue it for a longer time. Ideally, if you don't have an organism in the first biopsy, the second biopsy should be performed. If you did it for CT-guided biopsy first, you should go for an open biopsy second time so that you have more tissue sample and you can have a better diagnosis.
Thank you. Dr. Asif, do you have any comments?
Yes, I have. Areeba. There are many proponents who say that tuberculosis should always be managed conservatively, especially in Pakistan side. I
In
heard
Pakistan
many
side,
surgeons
yes.
discuss this. So even if neurological deficits are present, some of the surgeons tend to avoid doing surgery. However, I'm of the opinion
Yes.
that whenever neurological deficit present, surgery should be done. And moreover, if they are not doing that surgery within the tuberculosis, they are also not diagnosing. For example, if there's no pulmonary tuberculosis, it's an undiagnosed case of infection. They do not know that whether it's a MRSA or whether it's the TB causing it. And they routinely start these patients on ATT. And
ATT.
somehow, TT responds against these gram-positive organisms as well. What is your take on
Yes.
that?
See, we don't have a lot of literature on this. The problem with this is we are dealing with this TB, but we're not reporting it and we're not doing as much work on it as we should be doing. So that is why we don't have proper guidelines, algorithms regarding TB spondylolisthesis, that what should be done and what should be the algorithm that we should follow, like we have in pyogenic. So I think Pakistani surgeons, we need to work on that.
Dr. Ahmed, how prevalent is tuberculosis in Yemen side or in your region?
So we have many cases of tuberculosis in Yemen, but as you said, usually we treat patient conservatively. But if the patient has a neurological deficit, then we have to operate in these cases.
Agree.
And
So
what is usually practiced in Yemen about the patient with neurological dysfunction?
he said they operate them.
We do operation. If the patient with tuberculosis present with a neurological deficit, we operate. We should operate, yes. But if patient
Agree.
is stable, we can start with the conservative treatment. It's the best option.
Agree. So I think we do not have any more questions from the participants. So this was a very nice session, especially initially by Dr. Onur about the deformity. He very briefly summarized most of the aspects of the deformity, and then Dr. Areeba Tareq for helping us with a detailed presentation on the spinal infections. Thank you very much, Dr. Areeba. I think we would like to
Thank you.
conclude the session now, Dr. Ahmed. If you add something in the end, please do.
Okay. Many thanks to all participants today and to all the audience and to Dr. Yasser Khaybar for moderating this session and for Professor Onur Yaman for the nice presentation and Dr. Areeba Tareq for wonderful presentation and comparative presentation. And we are sorry that Professor Asif Bashir, he couldn't join us today, but it was very fruitful webinar and very nice webinar. And thank all for presentation with us, participation.
Thank you, Dr. Ahmed, for organizing these sessions for our learning. Thank you very much. Thank you, Dr. Areeba. See you again soon,
Thank you.
inshallah.
Thank you.
Thank you.
Inshallah. Allah Hafiz.
Allah Hafiz.
Thank you, everyone, and see you all, inshallah, next week. Thanks.
Inshallah. Allah Hafiz.